Now, once we have done the total hip arthroplasty, as you know, with every surgery, you can have complications. There are multiple complications which may be associated with the total hip arthroplasty. We can broadly classify these classification as those occurring peroperatively, that which can occur at the time of surgery, or they can occur in the early post-op, that is just after the surgery in the first few days, are those complications which will eventually occur later on, eventually after a few months to years after the surgery. Now, these complications, as I told you, are immediate or peroperatively, which may include airway problems, which is related to anesthesia. There could be anaphylaxis due to certain drugs or antibiotics which were given preoperatively. There could be blood loss or hemorrhage at the surgical site. There could be fracture or perforation, as you have sometimes what happens is when we are reaming in, we can lead to proximal femoral fracture or proximal femoral cortical perforation, which can occur as well, and that needs to be taken care of. There could be associated nerve injury peroperatively, or once we have done the surgery, this could lead to increased lamellin discrepancy, or there will be lengthening of one of the limbs as compared to other. Then once we have overcome all these issues peroperatively, there could be associated issues related to early post-op. This could be leading to venothromboembolism in the first few days to weeks to come. There could be associated urinary retention. There could be cardiorespiratory issues such as ARDS and development of pulmonary embolism. There could be associated with poor wound healing, wound dehiscence, and early periprosthetic joint infection as well, which could occur within the first 3 months or within the first 3 to 4 weeks as well. There could be dislocation. You have done this, but for some reason it was something wrong. There could be mechanical factors, there could be anatomical factors as well, and usually once the patient just tries to move passively as well, this results in a dislocation or a fracture of the periprosthetic fractures, which are also very common once the patient starts weight bearing. Then there are certain late factors which may occur after months to years, and these complications can occur after many years as well. For example, the most commonly it's severe osteolysis. As with any implant, eventually the polyethylene wear would set in and osteolysis would set in, and this would eventually lead to loosening of the implant, which may occur maybe at 10 years or 15 years of time, may occur early at 3 to 4 years or 5 years of time as well, which may lead to aseptic implant loosening, or this could be dislocation and recurrent instability, or there could be late periprosthetic infection as well, which usually occurs after many years. And usually the source may not be in the hip joint. There may be a distant source which may have a hematogenous spread leading to periprosthetic joint infection or periprosthetic fractures as well. Surgery may be absolutely fine. Patient may be all okay. Patient may be doing his or her activities of daily living, but patient had an RDA leading to periprosthetic fractures. A patient fell off the stairs and resulted in a periprosthetic fractures later on. All these could be the late complication, or the other late complication could be, which may happen after 6 months to 1 year, is the heterotropic bone formation. There may be different islands of bone formation in the muscles around the hip joint, and actually they may be problematic because they start to impede with the motion. And now there may be no pain, but the motion still may be limited due to heterotropic ossification at the hip joint. So all these complications, whether immediate or peroperative, early or late, they could be again lead to either another surgery or you need to do something about it. For example, if it's osteolysis, now this is, if you see it closely, you can appreciate there's a lot of lucencies in the acetabular component. There is lucencies in the different groin zones of the femoral component as well. Therefore, this implant is loosed. When this patient walks, this implant moves in and out, and as a result, this actually produces hip pain. Patient may be absolutely pain-free for a long period of time, but now patient starts that from last 1 or 2 months, I'm having pain again at the hip joint. If you see, this is another lateral view of the same joint. You can appreciate that actually the femoral component is not centralized, is pushing on one side, with increased lucencies on all sides, as well as you can see the lucencies over the acetabulum as well, with some form of a cortical break due to osteopenia. This is what happens in the osteolysis. This could be septic or aseptic. When we have a septic osteolysis, this can eventually lead to periprosthetic joint infection. Now, usually periprosthetic joint infections can be early. If it's early, within first 3 to 4 weeks, we may have to do the debridement, irrigation, and poly exchange would be more than enough. But if the infection occurs after 4 weeks, probably, then it's better to go for two-stage surgery. That in the first stage, you just do all the excessive debridement, you take out the metal component along with the poly, and you take out all the infective tissue and necrotic tissue as well, and you just put the cement spacer in. And after 2 to 3 months, once the infection has been resolved by use of IV antibiotics, then you go for redo a revision total hip arthroplasty. But as with every second surgery, the complication increases. Therefore, with the revision hip, there are different sort of complications which may occur because the bone is weak. It has become more osteoporotic, and there is increased chances of periprosthetic fractures as well. Now, if it's pre-operative prevention, how we can prevent infection? Because usually these implants are not cheap, they're quite costly. And in most of the countries, there's always insurance which can pay for it, but not all is the case over the world. And sometimes it's very difficult for the people to pay for even one surgery as well. So if you are doing the primary total hip, you should be meticulous about it, that there should be no infection, because this infection will not only lead to another surgery, would lead to a lot of catastrophic economic issues as well. And even there is a lot of, even where there is an insurance coverage, second surgeries is always, because you need more modular implants, they are further quite expensive, and they lead to increase actually surgical charges as well. So what are the factors in which we need to do to prevent preoperative infection as well? First and foremost is the good dental hygiene of the patient. No areas of chronic broken skin or ulceration. For example, patient, if there's around the hip joint, there should not be any cut or marks or any infected area in the or boil over the hip joint as well. There should be optimization of medical comorbidities. For example, patient should not be having a UTI or any other abdominal or genitourinary infection as well. And then screening patients for MRSA, because methicillin-resistant Staph aureus is the most notorious and most common pathogen which is actually leading to periprosthetic joint infection as well. Then it is always that methicillin sensitive Staph aureus as well. You need to screen that, and then you need to make it sure that you give them antibiotic which is according to the culture, and you treat them accordingly. Once they're infection free, then we can go for total hip joint arthroplasty. And then other complications of periprosthetic joint infection include other things which we can do to prevent these periprosthetic joint infections that is before going to the surgery. Now, there are certain things we can do during surgery to prevent periprosthetic joint infection, which include prevent bacterial contamination, ultra clean laminar flow in our operation theaters, then reduce theater traffic, that you need to have few surgeons on anesthetics, and all those who are needed should be there. There should not be too many people coming in and out of the OT. Use of specific surgical hoods, gloves, masks, all should be done. Prophylactic antibiotics to prevent infection, and if we have methicillin-sensitive Staph aureus, we should be giving the antibiotics according to the culture and sensitivity. Then intraoperative fluid balance optimization as well, because problems, if there is associated increased blood loss, hemorrhage, or fluid disturbances, this can prelude patient to increase infections later on as well. And use of tranexamic acid, because what it does is it reduces the blood loss operatively surgery, and reduced blood loss means reduced chances of infection. Now coming to the other things which we need to do once we have done before surgery and perioperatively, what else post-operatively we need to do to prevent early and late post-operative prosthetic joint infection. That is always good wound care. If the dressing needs to be changed, it should be done in a sterile environment. Then pain management and nutritional. We don't want them to develop hypoalbuminemia and wound dehiscence. And once wound dehiscence would develop, there will be increased chances of having an infection, an airborne infection as well. What if the patient does develop despite all this? The patient has developed, then we have to go for revision total hip arthroplasty. As I told you, the problem could be that once a patient has developed early periprosthetic joint infection, that is within first 2 to 3 weeks, and at max 4 weeks, then probably we can go for absolute surgery, that we can go for excessive debridement, take out all the necrotic tissue out, they remove all the debris, and we can go for poly exchange as well, along with the use of IV antibiotics, which are culture specific. But if it's after that, then probably it's better to go for 2-stage surgery. Although 1-stage surgery can be done, but usually it's difficult to get rid of infection in the joint with just 1-stage surgery. And then you probably will have to go for 2-stage surgery in form of a revision total hip arthroplasty. And when we are doing the revision hip, we usually use modular stems, long stems as well, and bone grafts and different cages and designs can also be used to actually prevent the dislocation or further complication of revision total hip. As you can see, if this is once happens, this is the total hip was done, and this revision hip has been replaced by use of, because there was a lot of lysis over here, they've used a cage with bone graft along with screws as well, and cemented total hip joint replacement has been done. Now what is important is that you need to understand that whenever we are going for revision total hip, we don't need to go for cemented always. Sometimes we can go for uncemented total hip joint replacement as well. But considering the age of the patient, bone quality, and the times elapsed since infection, is all these factors which determine whether we have to go for non-cemented total hip arthroplasty or cemented total hip arthroplasty.